now like to welcome Professor Caroline Miller, who is the Director of the Health Policy Centre based at SAMRI, to the stage. Caroline is a NHMRC emerging leader, a Heart Foundation Future leader, a fellow and Beat Cancer Principal Research Fellow at the University of Adelaide, many other things as well. The centre that Caroline runs delivers evidence to inform public health policy, health promotion, particularly to reduce preventable burden of non-communicable diseases. It undertakes programs of research in tobacco control, obesity prevention, and related to alcohol. Professor Caroline Miller is actually most known for her work worldwide in public health for tobacco control, in which she has specialised for over 20 years. She was one of a select group of scientists who advised the government on the world-leading plain labelling for tobacco packaging that Australia has led on, and has many other accolades, awards and research programs to her name. Caroline, please come to the stage, and please welcome Caroline to her talk.
Thank you, and thank you for the invitation to speak. I'd also like to acknowledge that we're meeting on the traditional lands of the Kaurna people, pay my respects to elders past, present and any First Nations people participating today. So I'm more of a policy person and a non-communicable disease prevention person, but COVID has brought me more into the communicable disease and a little more into the healthcare space, which I'm going to talk about today. So at the Health Policy Centre, our core skills, as I've said, are around primary prevention. We bring to it training in psychology and economics, which really are both sciences of how to change human behaviour, just in different ways, plus public health and epidemiology skills, policy research, evidence synthesis. And one of the things I think that's sort of unusual about our centre is that we spend a lot of time working really closely with policy makers and advisors in a sort of, key trusted advisor sort of a role. So we do a lot of work providing evidence briefing for people who are in government and for elected officials to inform their real-time decision making. And so as people who work in healthcare settings as well as policy also understand decisions have to be made now, and they don't really have time for scientists to go on away and accumulate evidence, whereas people who work in academia understand, of course, that science has to be, constructed and built in a robust way, and that takes a long time. And so part of what we try to do is sort of bridge that gap between, the scientific work and world, as, like JBI does, and the real-time decision-making. For us, it's about policymakers. And so the work that we've done has helped inform policy change, notably in tobacco control, population-level interventions, and ultimately changes in behaviour. And we've seen that very clearly in tobacco control, particularly in Australia. Less so in obesity and alcohol, which are our other fields of work. So when COVID came about, SAMRI offered, as did many other places, to assist, and one of the requests that came back from our Chief Public Health Officer was to provide a sort of, a way of accessing the evidence for her decision making and for the state's COVID task force decision making in a rapid way. So we brought our public health and our public health epidemiology and our evidence synthesis skills to the fore there, and then we brought also in specialist expertise in virology. So Steve Westling, who runs SAMRI, is a virologist and an infectious diseases physician. And then we brought in other people on different topics as we went. And what we produced was a service producing rapid synthesis of evidence. And so this involved us doing a rapid review of available evidence, which some of which was peer reviewed, much of which wasn't, and was in preprint or government reports, and sometimes even media statements. We would summarise and contextualise that for Australia, because our context here in Australia has been really significantly different to many other countries, and also point out the implications for policy. And then we would deliver that to our Chief Public Health Officer and our State Transition Committee. They would make policy decisions using that information as part of their decision-making process, and we would also, sometimes our work would go up to AHPPC, which is the federal equivalent. So we've done lots and lots of these, and I suppose they sort of fall into 5 big questions around COVID-19. So, what are the features of the virus? And these are still really relevant, actually, as we're dealing with variants. So how contagious is it? What are the mechanisms which lead it to spread? Which ones of those mechanisms are most important? Is it face-to-face contact? Is it surfaces? How does it present clinically? That was important very early on. What's the hospitalisation rate like? What's the case fatality rate like? Then how do we detect the virus? So what are the best, most effective, most sensitive and cost-effective mechanisms for testing? What symptoms should we be looking out for? How does contact tracing work and what are the most important things within that? Then, of course, how do we control the spread? Lots of topics to cover there. Will our health system cope? Which was really, our biggest question in the first instance. And actually, we've eliminated COVID essentially in Australia. And so this is less our conversation now, but very much was our conversation at the start, and I think will become our conversation again now that we're talking about opening up a little more. So, flattening the curve was a big issue at the time, which wasn't about eliminating COVID. Of course, it was about how do we keep our caseload going into our hospitals below the point of available ICU beds and ventilators. And we had PPE supply issues at the start, of course. So how do we make sure our demand doesn't outstrip our supply, because that's when the case fatality rate goes through the roof, which is what we saw in countries like Italy. And then, of course, what everyone's interested in, how do we safely open and recover economically? So the first topic that we did was schools and COVID. So we took this, every topic presents both a question of policy, which is, what should we do in the state around schools? Should we keep our schools open? And behind those questions of policy, there are questions of evidence. So the question of evidence was, what is the impact, or what do we think the impact of closing schools would be on transmission of COVID? So how important is it? What sort of level of impact would it make? And so what should we do? So this was at the start of the pandemic. There was lots of concern and unknowns about the mechanisms of transmission. There were modelling studies from overseas with very high media attention. And the Teachers Union in South Australia launched a campaign arguing for schools to be closed as well. So the published evidence was actually pretty limited to work from. There were studies of transmission that were peer-reviewed that indicated that children may be at lower risk of infection. It was very clear even then, and has continued to be clear, that children are less likely to become unwell. There's a very strong age relationship with severity of COVID, as people would understand. Mostly children who are infected are asymptomatic or have mild symptoms, and it appeared the case that transmission was possible, but children's propensity to transmit appeared to be low. So there were modelling studies. There was a lot of complexity in the modelling study literature, because a lot of modelling studies had effectiveness of closing schools as an input, as well as presenting it as an output in the findings. So we had to unpack that. Probably compelling at the time was the notable absence of data around children's transmission. So disproportionately low incidence, apparent lack of evidence of asymptomatic transmission, different to pre-symptomatic transmission at the time. Lack of transmission in schools despite cases in New South Wales. So it's a bit hard to see, but every sort of cluster up there represents a case that's been present in a school, and then the red indicates a case of onward transmission. So we were seeing lots of sort of cases popping up in and around schools, but an absence of transmission. And then we had information from New Zealand that said that transmission around schools related predominantly to adult events, so parents getting together rather than kids. So we put this together. So the other things we covered, which is sort of, I suppose, contextualising it in a policy setting, was also around potential consequences of closure. So what we knew about the impact potentially on kids' physical and social wellbeing, and also their safety. home isn't a safe place for every child. Considerations around impact on the health workforce. So if we closed all the schools, what would happen to our health workforce's ability to come to work? And potentially, if older people were taking care of kids, then, did that create a bigger risk beyond the risk of having the kids in school? So we did this 3 times to check the evidence 3 times for Nicholas Spurrier, probably mostly because of the campaign of the teachers, and that evidence was used both in this state and also by AHPPC across Australia to keep public schools open. It also created an environment as a policy decision where parent choice was accommodated. So the school was open, kids could go to school. If parents didn't feel comfortable with that, online learning was accommodated. Okay, so the second example is around contact tracing. So the policy question was, when an outbreak occurs, what matters the most? So we've got this many contact tracers. If it starts to get out of hand, like it did in Victoria, can corners be cut, for want of a different term? Resourcing is always limited. What do we really need to focus on to get the return? And the other question that we were asked was, does contact tracing even really matter? And a lot of these questions were, how important is this intervention or that intervention in COVID control? So there was a lot more evidence around contact tracing. So we did it twice. We did it once for the state government, and then we did it once again for the federal national contact tracing review. So we had a lot of papers, and we also had international exemplars to draw on. So different countries who had different controls to Australia. For example, they may not have been using lockdowns, but they had very intense contact tracing. So contact tracing 2nd and 3rd generation contacts and quarantining those contacts, which is quite different to what we were doing in Australia. So we found that contact tracing is absolutely essential for COVID control, both contact tracing forward, so who a case speaks to, and trying to find out where the case came from, which might sound sort of obvious to us living in Australia, but not every country was doing that. We also found that contact tracing needs to occur at a pace, so you can get within 2 to 3 days, get about 80% of close contacts quarantined, then you can maintain control. On the other hand, if you're at 4+ days, or you can only get less than 60% of people in quarantine, that's when you lose control. So that's what the state health departments need to know. What are our KPIs, so we know we can keep the state open, and when do we think we're getting out of hand and we need to lock down? And really, a lot of hard lessons were learned in Victoria. Scalable workforce is important, so bringing in med students to build up your workforce when this sort of stuff starts to happen. Technology is hugely beneficial. We've got a pretty low appetite for this in Australia, but lots of countries in Asia do a lot more digital surveillance of their systems, and that's a really effective and powerful part of their contact tracing. And transmission's uneven as well. So we know that COVID, and we've learned all these things over time. We know that we've got a sort of like almost an 80-20 split on people who do transmit COVID a lot and people who really don't, in lines of transmissions that die out. But of course, you've got no way of knowing who those people are. So you just have to get everybody sort of isolated. So our work, so there was a national contact tracing review done. The author said that the SAMRI evidence updates provided the scientific underpinning for the whole report, so there was no other group that could produce that work as quickly and as effectively as us, so they used our work and made recommendations which were absolutely in line with the work that we'd synthesised for them, so scalable workforce, attendance recording, which is of course our QR codes, and key metrics around getting close contacts quarantined really quickly. And that's what underpins our practice now. So just my third and final example is temperature screening. So the question was, what is the predictive value of temperature screening for COVID-19? That should be, of course. So the policy question there is screening temperature in public places worthwhile? So this was of interest for hospital entrances, retail. If you go to a Mac centre, you'll get your forehead screened. Aged care, should we be temperature screening aged care? And what about our airports? So this kind of broke down into, 5 different sort of questions, 5 different scientific questions. The first two, the first one is really how well does elevated temperature predict active cases of COVID-19? And that was, that was the sort of first scientific question. And at the time, and I'm not sure that we're still publishing data on this at a federal level, but at the time, the prevalence of fever in a confirmed case of COVID was only 47%. So less than half of people who have COVID will present with a fever. And a cough, in fact, was a more prevalent symptom at the time at 69%. And of course, elevated temperature is not present in people who are pre-symptomatic. So firstly, we're only going to find half the cases if we screen, at best. So then the second question is, how good is temperature screening technology in detecting elevated temperature in screening settings as opposed to in a clinical setting? And the answer really is that the non-contact thermometers measure skin temperature, which isn't as good. They've got quite low sensitivity and low positive predictive value. And so they're not actually very good at accurately assessing temperature. In that sort of way, and also they were used very widely for SARS in different countries, including Singapore, and they weren't found to be effective in either picking up positive cases or, so accurately finding sort of positives and negatives. So the other considerations, of course, as medical people understand, temperature fluctuates, medication can mask it, probably better than self-report, might act as a deterrent to someone who's unwell entering a setting, so better than telling people to stay home if they don't feel well, might create a false sense of security. The sort of practicalities when you get into a health service setting might be, we've got questions of feasibility, infrastructure and cost. So you've got people sitting at the entrance to every hospital in the state, so you have to pay those people, you have to get that technology, you have to monitor everyone who comes through the door. What do you do when you have a positive temperature reading? So do you put them into secondary screening to make sure it's more sensitive? If you're in a retail setting, you can just say, sorry, you can't come in. If you're in a workplace, do you send that person home? Do you decide they need to go and have a positive test? They have to go and have a test before they can come back to work. So there's a lot of sort of, on the ground feasibility questions around that. And of course, so then, then the risks of screening versus the risks of finding a case are going to vary by setting. And so this is the policymaker's, decision, of course. So if you're in aged care, where having a positive case come in and not be detected is catastrophic, you might have a higher appetite for funding that intervention, even though it's not particularly sensitive. Airports have a lot of people there anyway. Hospitals and workplaces, I would say less good return on investment. So in terms of impact, Leslie's not here, so I can't check whether this is what determined what was done at the entrance to the Royal Adelaide Hospital, but we don't have temperature screening in our hospitals locally. There has been an enormous amount of media interest in this, and so we've done media work on this sort of, I think, kind of 3 or 4 times over the course of the year. So that's sort of been the impact there. So as I said, we've published, we've done more than 25 of these and published. We've done them on sort of almost every practical sort of policy question that you could imagine. Right now, most of our work is focused around watching and monitoring the real-world effectiveness of vaccines. So, how much of an impact do they have on reducing cases? Quite a lot. Italy, about 2 days ago, published data that said it was about 80%. What about hospitalisations? We're looking at about 90% impact on hospitalisations, and then I think 95% impact on mortality. So really, really good, strong real-world data coming out of the UK, coming out of Israel, and coming out of Italy, places where they've done a lot of vaccination and a lot of monitoring. International students are a hotbed issue here as well, so we've been doing some work around that too. And they're all published on the SAMRI website if you're interested. So in terms of clinical settings, we did some of these at the very start. So we did one on ICU triage, so, which people who come through the door are most likely to end up in ICU. We did one on what should be happening around COVID and pregnancy and breastfeeding and around cancer and immunocompromised people. But then Monash, I think, leads the National COVID-19 Evidence, Clinical Evidence Task Force, which we just partner in. So, and that's a much better setting than our setting. I think our strength is policy and their strength is clinical guidelines. So they produce clinical guidelines to an NHMRC standard on a whole range of different issues around COVID, and they've published those and made those available for health settings and clinicians. So a couple of other things we've collaborated on very briefly. There's been a national sero prevalence to try to get a sense of sort of the prevalence of antibodies in our community, to try to work out, we know how many cases we've identified, how many other people have produced antibodies that have been exposed, to give us a sense. So that work hasn't been published, but we probably expect it to be similar to other countries around the world that have published these sorts of results. So, that for every case we find, there's probably a reasonably substantial number of other cases, which in many ways is good news. And also we were doing work trying to determine the exact rate of childhood transmission in households, which became hard in Australia because we started putting people who had COVID into isolation, which was the right thing to do from a policy point of view, because households are actually the main driver of transmission. So in summary, people have to make these decisions against very tight timelines, and the decisions will be made and cannot wait. And we're in the middle of that at the moment. We've got a story on the front page of the Advertiser talking about hoteliers wanting to go to 100%. Putting a lot of pressure on our decision makers around vaccine rollout, and so that's the policy and evidence question that we're in the middle of right now. So our question is, what does the Chief Public Health Officer, Police Commissioner need to know to make those decisions? So we take the question that's a policy question, define the scientific question, do a rapid research for all potentially relevant information, review that evidence, the high quality evidence, the sort of medium quality evidence, the less high quality evidence across published, government, other sources. So we present the evidence and also the quality of the evidence so people understand that. Contextualise it for the Australian policymaker or the South Australian policymaker. Try to give them everything they need to know to inform the decision making, but we do not tell them what to do. So it's not our job to tell them what to do, it's just our job to help them to access that science and then deliver that within about the space of 1 or 2 weeks. So this is the team that's done work on it that I'd like to acknowledge, and thank you for your attention.
Thank you very much, Caroline. Do we have some questions for Caroline on this remarkable topic? Just while you're warming up your brain cells. I know you haven't had coffee for a while. Caroline, this is really remarkable work. I was intrigued by your notion that there's a policy question and then you develop a scientific question. What's that like, trying to then get a consensus back with the people that want the evidence that these are the right scientific questions that relate to their policy?
Well, I think we ask them to define their question as precisely as they can, and then also explain, I suppose informally to us, the policy decision-making position that they're in. And then we go away and go, well, these are probably, in many ways, we're sort of stepping out the logic to help them see what they know what they have to do, but to sort of, from our point of view, this is a scientific question, here's the answer to that, here's another scientific question, here's the answer to that. This might be a more contextual question, like for schools, what will happen if we do close schools? This is what we know, this is what is evidence-based, this is what is speculation and opinion. And a lot of the time people, with COVID, there's a huge amount of opinion published in lots of really quality journals, and so you can go through and actually scope through some of that and say, here's 4 published opinions on this topic, and this is the strength of evidence that does or doesn't sit behind them. Yeah.
I guess thinking about the evidence, particularly when you get to, we want guidelines for clinical care decisions, such as should somebody get an ICU bed or not. I mean, that's a really big decision.
Yeah.
And how do you manage that? Were you working with clinical stakeholder groups, or like do you reach a negotiated point with the evidence to feed into a guideline?
So we didn't write a guideline, so that's what the clinical evidence guideline people do. Yeah, that's the Monash group, right. And that's good because they do that in a much more systematic way. What we delivered, so the question that we were asked is, how can what are the predictors of ending up in ICU? And so that's what we did a review on. We did so this is every study that's been published in the world to date, where the end point has been ICU versus not ICU. Yeah, and went through. So there was a whole lot of things that were sort of demographic, age, gender, weight, actually have turned out to be really strong predictors of poor outcome with COVID. We listed all the clinical diagnostic tests because people were publishing all of those as well. And I think probably what we ended up delivering was something that really, I suppose reinforced what observations the clinicians who were on the ground in the settings were making as well, but gave them access. They don't have the time to review every paper that's been published around the world on the topic, so we gave them a synthesis of that. Sorry,
I'm not going to let you go yet. Any other questions? Thank you, Ed.
Just on your last slide there was that interesting snippet of the work that was around contextualising
the
evidence. And the example you used, the current question, restaurants open up to full capacity.
Yeah.
Now, the policy making that decision, that will seemingly have implications for health, for the business and their finances, for employment, and the list kind of goes on and on and on.
Yeah.
So how do you get that balance right when you're trying to deliver that in 2 weeks? Or is that a negotiation point for policymakers as well?
Yeah, I think mostly we're asked to focus around health. I'm trained in economics as well, so I would say I'm literate enough in economics to be able to provide some perspective on that. Sometimes we collaborate with economists. I've done some work for Queensland Health, which was a much bigger project where we had a sort of health stream and an economics stream working side by side to quantify that. I suppose, with the issue around should we be 75% or should we be 100%, it's a question of, risk, isn't it, and risk management. So you can say we've got no COVID in the community in the state and we haven't had an outbreak for a long time, and that's how a lot of people will feel, and that's how the hotelier will feel. They'll say we shouldn't have any restrictions. And that's okay, except that in the event of a case, how many people are signing in, how many people have to go into lockdown. It's the same as Adelaide Oval. The compartmentalising, this many people check in, this many people would have to go into supervised quarantine, this many people would have to stay home. But we're not locking down the whole state. So it's a trade-off, I suppose. So the way we bring it's not our job to make the policy decision, but the way we bring science to that is we say, okay, well, this is what we know about how good the vaccines are. This is what we know about how good the vaccines are likely to be to prevent transmission. So we can use that to try to model when we can get to points where we won't have uncontrolled outbreaks or outbreaks that will overwhelm our health system. So we've got a community who sort of expect 0 cases. Then we've got the question of, well, what's going to overwhelm our hospitals and what's going to send our whole state into shutdown. So we look at the science, how the science emerges around vaccines, which is a protective mechanism. We know about contact tracing already, so that's how good is our compliance with contact tracing, and can we get 80% of people who are exposed in the event of a super spreader being present. And then we also know we have much different levels of risk around different physical and social settings. So we know environments where people, and that's based on where have we had clusters that have gone out of control around the world. So, we know nightclubs lead to super spreading, and that's because of the way people behave in nightclubs. They're closed in, it's poorly ventilated, there's a lot of alcohol, there's a lot of physical contact. Same for weddings, people know each other, they're having a great time, there's a lot of spitting and singing, and so these things lead to super spreader events, unfortunately. And if you don't have a super spreader, it's fine, but if you do, that's where you have to do your contingency planning. So it's about appetite for risk, really, at the end of the day, because we're always you know, you're always kind of 14 days behind, I guess, because not every case comes forward and gets sick you know, which is great, but it also means you might have 20 cases before you have a person that needs medical attention. And that's what happened with, that's what happened with the Parafield cluster as well, yeah.
Well, that's a superb, comprehensive answer. One more question at the back, please.
Questions that, as already mentioned, you guys wouldn't make any recommendations. Would there be anyone who would make recommendations, or you just present the evidence to the government and they will make the decision?
Yeah, they make the decision. And I mean, it's not our job to tell them what to decide, I suppose, because they, you know, as I've said, we focus on evidence around COVID control. And as a government, they have to think about COVID control, they have to think about economic impact on the state, they have to think about social impact. So that's not our job. Our job is to tell them this is the weight of evidence to inform that decision. So we try to give them everything they need, but not tell them what to do, because, you know, that's their role, not ours. Yeah.
There are a few systematic review experts in the room, and on their behalf, doing reviews in the future outside of the context of a pandemic, would you go for pre-publication preprints?
I don't think it's not preferable, clearly. I mean, I don't think and as we've moved through, I guess, you know, we've sort of been less and less keen on including preprints, but at the same time, it's sort of hard to exclude them completely because it's such a rapid moving issue. So far from ideal, definitely, including a lot of preprints. This is why we're explicit about what the quality of each different
I thought that might trigger Ed.
Just a very quick one. We're talking about globals and contextualising. Is it part of your process to see if someone else out there's answered these questions?
Oh, absolutely. Yeah, absolutely. So, and there's a couple of, and we pick that up in our work. So there's a couple of groups. There's a group at Oxford who do a similar sort of a function. But I think actually, unfortunately, there's much less of this sort of work done than you might imagine. And I think a lot of it probably, you know, it probably happens behind closed doors in a way. I mean, a lot of the work that's done federally, I don't think ever really gets published, and that's fine, you know, the decision makers can all see it. But one of the things that we've been really pleased about is we give it to the policy makers and give them a couple of days to read it before we publish it, because we don't want it being in the advertiser before they've even had a chance to get to the end of the document. But we publish everything we do a few days after, and Nicola's been great about that as well. I mean, part of that is about, well, why would everyone want to be doing this, you know? It's such a waste of everybody's time and duplication of effort. And as the contact tracers review authors said, it saved them having to commission the work because we'd already sort of done it. Yeah.
Well, thank you very much, Caroline. What a wonderful talk.